Hi, everybody. Dr. Horn with infectious disease. Today we're going to talk about fluoroquinolones. Fluoroquinolones are one of the most used antibiotics. I think there was a study that said about 25% of the patients that are on antibiotics are on a fluoroquinolone. So I think it's good to go over this topic a little bit. You know, I think they're excellent drugs. They're very, very good. They do have some side effects, some issues with them, so I think it's important to talk about that. But overall, they're very, very good. Um, Now, if you have any questions, you can always put it into the chat. We're not going to be completely comprehensive. This isn't meant to go over all the little details about fluoroquinolones, but I do want to hit the big points. And So we'll go through and I called it a rapid review, but it's not meant to be completely comprehensive. It's meant to just hit the most important parts. Let's see. All right, so when we talk about fluoroquinolones, we're talking about Cipro, Levo, Moxy, and Dalafloxacin. So I think everyone's familiar with these. You know, a lot of hospitals they'll choose either what they want to have on formulary, either Cipro or levofloxacin, and only carry that. And the hospital that I'm at, they we have levofloxacin on formulary, but we don't use Cipro. So if someone, when we discharge a patient, we could put them on ciprofloxacin, but we'll talk a little bit about the differences between levofloxacin and ciprofloxacin and why a person might choose one over another. In general, ciprofloxacin covers gram negatives very well, but doesn't cover gram positives. Levofloxacin covers gram positives. So when you hear people say respiratory fluoroquinolone, they're talking about either levofloxacin or moxifloxacin because it also covers some gram positives where you wouldn't give ciprofloxacin to cover gram positives. So Cipro is good for gram negatives. Levo has the spectrum of activity is a little bit larger, where it includes gram positives like strep and strep pneumoniae, so that's why you would consider using it for a pneumonia because you're going to cover strep pneumoniae. Moxifloxacin um, covers strep, so you can use it for a pneumonia. But it doesn't cover Pseudomonas, whereas Cipro and levofloxacin can have Pseudomol activity. Moxifloxacin doesn't cover Pseudomonas, but it does cover a little bit more anaerobes. And dalafloxacin. Dalafloxacin is pretty new. We're gonna, and it's essentially you can kind of think of it as another fluoroquinolone that does have some gram-positive coverage. They do talk about using it for skin and soft tissue infections, but we're going to mainly focus on Cipro, Levo, moxifloxacin because that's what you'll mainly see. Now, I was saying that as far as formularies go, places usually either choose Cipro or levofloxacin instead of carrying both at the hospital. You could just carry one, like levofloxacin, moxifloxacin. Some places, like uh, for instance, the VA, if you order moxifloxacin, the pharmacy will change it um, immediately, so they'll change it without telling you to ciprofloxacin or levofloxacin. Um, they change it immediately to levofloxacin with metronidazole to give the same coverage, but since moxifloxacin uh, is more expensive, they have that automatic conversion. So if you order moxifloxacin at the VA in Omaha, they'll change it to levofloxacin metronidazole automatically. So it's important that if you want to give that, you have to put it in the comments and say, I do want moxifloxacin. Please give that. Now, different classes of antibiotics. Here's an overview. Now, this is showing a timeline of when they were created, just to give you an idea. So, when in the timeline, the scheme of things, um, these became available. So you can see the quinolones over here, 1960s. So they're pretty old. And there are some quinolones that have come and gone, but sometimes it's interesting to look at timelines. This isn't the most up to date because we've had a number of antibiotics that have come out rather recently, meaning in the last 5 to 10 years recently. Fluoroquinolones, mechanism of action, inhibits bacterial DNA topoisomerases like DNA gyrase, and it essentially stops the cell from replicating, and it stops the cell from replicating by interfering with DNA transcription, replication. Now, in the past, people would make a big deal out of, is it static? Does it stop the cell from dividing and then the cell dies over time? Or is it lytic and does it kill the cell? Um, like daptomycin, where it pokes holes in the cell and kills it quicker. Actually, static versus lytic is not as important as once thought. So this is one of the myths that has been debunked. Uh, Dr. Brad Spellberg, who is at University of Southern California, has written a lot of articles, and one of the myths that he just debunks is, the mechanism of action and if it's important, if it differentiates and says one antibiotic is better than another. So that is no longer the case. And it's actually, you'd have to look at it more of um, case by case basis with which antibiotic is better in the studies and what does it show. So as far as the pharmacokinetics go, they're very well absorbed. So it's 100% bioavailable, meaning the dose, if you're going to give someone 750 PO, if you give a pill 750 milligrams, versus if you give IV 750 milligrams, it gets in very well. It's very bioavailable. And that's very important when it comes to the difference between giving IV versus giving PO. Because the most important thing when it comes to antibiotics and how well they work for a person is you want it to work for the bacteria, and you also want it to get to the site where it needs to go. So does it get into the organs that you need it to get into? Is there a good concentration at the location where there's an infection? And that also has to do with blood flow and how well a person's their perfusion to the area that has an infection. So it's usually we see infections in areas that have very poor perfusion. That would be like the feet can have very, very poor perfusion if someone has peripheral arterial disease, someone smoked for a long time, has diabetes, and has issues with blood getting to, their feet and their toes. They're much more prone to getting infections in those areas. In contrast to places with very good perfusion, like the face has very good perfusion. Someone has a cut on their face, it bleeds a lot. So we usually don't see infections in places with very good perfusion as much as places without good perfusion. But if, the immune system and the perfusion is poor, if the perfusion is poor and the person's immune system can't really get there to help, you can't have an inflammation response in those areas, then even antibiotics may not help very much because the antibiotics won't get there to help as well. Um, Fluoroquinolones get into a lot of organ systems very well. They get into the urine very well. Excellent penetration into most tissues and into bone as well. Now, I just wanted to touch on this because as far as time-dependent versus concentration-dependent antibiotics, the time-dependent antibiotics, it's time above the MIC is what's important. So you want to make sure that it spends the most time above the MIC to have the greatest effect and to kill the bacteria the best. So these are time-dependent antibiotics like beta-lactams, like vancomycin, and you want high plasma concentrations versus for a long time. And it has a short post-antibiotic effect. So that's after the antibiotic is below the MIC. Uh, how well does it continue killing the bacteria after it falls below the MIC? And it's very short with time-dependent antibiotics. You want the most time above the MIC versus concentration-dependent killing. Concentration-dependent is where Um, you have better killing of the bacteria with high peaks. So concentration dependent antibiotics, examples of these are like aminoglycosides, so tobramycin, gentamicin, and fluoroquinolones. So for this reason, if you're giving a fluoroquinolone, like levofloxacin, ideally you want to give a high concentration, like a high dose, once per day is okay with levofloxacin. So you get a high concentration once per day, and then you have this prolonged post-antibiotic effect, which is thought to be because of uh, the when it binds, it doesn't let go. So so when it binds, you know, if it binds and then when the concentration falls, it lets go, that's one thing. But if it has irreversible binding to its receptor to where it binds, then you have this long post-antibiotic effect. So if you're giving gentamicin for synergy, you can dose it a low dose multiple times per day. But if you're giving it for septic shock, you would give once daily high doses for several days is what I do with septic shock. If someone's doing poorly, you can give them high dose once daily um, for 3 days or so. And you get this high concentration, long post-antibiotic effect. And as far as activity, fluoroquinolones are really known for their gram-negative coverage. So gram-negative bacteria is the main target, enteric. So that's going to be gut stuff. So it's going to cover abdominal infections very well. So you're covering gram negatives that what you have in the inside of your intestines, your just normal flora, is going to be covered very well. So if someone's having abdominal infection, levofloxacin or ciprofloxacin would be good options. Now, if you're going to cover abdominal infections, there's a one drug choice or a two drug choice. And that's usually has to do with if it covers anaerobes or not. So because levofloxacin and ciprofloxacin don't cover anaerobes very well, you would want to give either levofloxacin or ciprofloxacin plus metronidazole to cover the anaerobes. So a one drug, that would be a two drug option. A one drug, or you could give cefepime plus metronidazole, ceftriaxone plus metronidazole. A one drug option would be piperacillin tazobactam or a carbapenem. Um, Carbapenems have good anaerobe coverage. Piperacillin tazobactam, good anaerobic coverage. Moxifloxacin has some anaerobic coverage, so that would be an okay one drug, um, uh, one antibiotic for abdominal infection. Now, Neisseria species, it can be good, but there is some resistance to Neisseria gonorrhea, H influenza. Now, Pseudomonas is important to know because moxifloxacin has no activity, but Cipro, levofloxacin, dalofloxacin do have activity. So just because it has activity doesn't mean it works in all cases. So you'd want to check the susceptibility report of the organism that you're trying to treat. So you'd get a culture, and then you'd see does it work for the organism that you're treating. Now, because it has so it does have Pseudomonas coverage, but I said in the start that fluoroquinolones are one of the most used antibiotics that we have, and they're so used that the uh, the likelihood of it working or the antibiograms for a lot of places show that the resistance has been increasing and increasing and increasing. And for that reason, if someone is extremely sick, so if they're in the ICU or they're having septic shock, I wouldn't use a fluoroquinolone alone because of the rates of resistance. So it would be better to give a carbapenem if you want good pseudomonal activity, especially, or cefepime if that works well for your antibiogram for your institution. So just because it does have pseudomonal coverage doesn't mean it would be the best option. Another thing here would be if it works for E. coli, like if you're treating urinary tract infection or a prostatitis and you want to make sure you're covering E. coli well, you have to look and see what is the antibiogram in your area because it gets into the prostate well. It has good penetration there, but it may not be very good on your antibiogram. And so it may not be a great option because the likelihood of resistance. Now, the other thing I'll say about that is if someone is outpatient and perhaps they're getting treated for a pyelonephritis or a urinary tract infection, if they're failing and they're getting worse and worse, and then they go to the ER and they get admitted to the hospital, if they were getting an antibiotic like levofloxacin or ciprofloxacin as the outpatient, and then they go inpatient, I wouldn't use the same antibiotic that they were getting before if they were already failing it. I just wanted to mention that as well. Now, gram-positive bacteria. So their fluoroquinolones do have activity against MSSA, MRSA, and coag-negative staph. Levofloxacin, moxifloxacin better than ciprofloxacin. So that's why, um, you know, well, respiratory fluoroquinolone would be strep pneumoniae activity. But just because they have activity doesn't mean I would use it, right? So resistance can emerge while you're treating. So if someone is treating, MSSA or MRSA because they have a susceptibility report that shows levofloxacin would work for it, while they're treating, it may become resistant. So if the patient is failing and you did another culture and susceptibility, it may show on the next one that it's resistant. So they say that it's only, I think it's just um, one, uh, uh, the resistance can emerge while you're treating. Part of it is just one little change. Sometimes you need multiple changes. So in order for something to become resistant. But if it's just like one base that changes or something very simple, then you don't have a lot of cushion. You don't have a lot of space before you develop resistance, whereas sometimes you need multiple changes to take place before you get resistance. But if it's only, um, a simple uh, uh, one base pair that changes, then it's very easy to develop resistance while you're treating. Now, other pathogens. This is important because Legionella is covered. We use fluoroquinolones like levofloxacin very often to cover Legionella. So Legionella um, isn't covered by beta lactams. So if someone's if they have a Legionnaire's disease, they have Legionella pneumonia, and they get admitted to the hospital. If they're very sick and they're in the ICU, it's the recommendation is to give something that covers Legionella, like either azithromycin or levofloxacin with the regimen. So they might get vancomycin, piperacillin, tazobactam plus levofloxacin. So that would be the reason for the fluoroquinolone if someone is extremely sick with a pneumonia coming in from the community. If someone's in the hospital and they develop a hospital-acquired pneumonia, the regimen is the same. It's vancomycin, piperacillin, tazobactam plus levofloxacin. It's the same regimen, but the reason for the fluoroquinolone is different. If it's a hospital-acquired pneumonia, the reason for the fluoroquinolone is to cover Pseudomonas because the fear is that they develop Pseudomonas pneumonia while in the hospital. So the regimens are the same, but the reasoning behind giving the fluoroquinolone is different. So another thing to kind of think about is if someone has a pneumonia and they're not getting better on beta lactams, then could they have Legionella? Do you need to add something like a fluoroquinolone or azithromycin, macrolide? Other things, Chlamydophila, Mycoplasma, Rickettsia, Coxiella burnetii, Q fever. Um, So anaerobe, so moxifloxacin, dalafloxacin have some anaerobic activity. Cipro and levofloxacin do not. And then mycobacterium, if someone like Mycobacterium tuberculosis, levofloxacin has some activity, moxifloxacin has some activity. So if a patient comes into the hospital and you're thinking they might have tuberculosis, then ideally you wouldn't be giving them levofloxacin because you don't want to give them like a one drug treatment for tuberculosis. Oh, so someone asked, doesn't Zosyn cover Pseudomonas? Yes, this is a good question. So if someone's in the hospital and develops hospital-acquired pneumonia, this is a very good question. So if someone develops a hospital-acquired pneumonia, I mentioned that they would get vancomycin plus piperacillin tazobactam, like plus Zosyn, plus levofloxacin, and the levofloxacin is there to cover Pseudomonas. And the question is, doesn't the piperacillin tazobactam, doesn't the Zosyn cover Pseudomonas? Yes, it does. That's a good question. But if it's a hospital-acquired pneumonia, if they're very sick, you would give both the Zosyn plus the levofloxacin to cover Pseudomonas. So you'd be double covering the Pseudomonas with two different antibiotics that work by two different mechanisms. So, and whether you give which antibiotics or whether you need that double coverage depends on your antibiogram and how good is the Zosyn for the Pseudomonas in your area. So if Zosyn in your hospital covers very well, if it's like 95% activity, then you wouldn't need another antibiotic on top of it. Yes, I'm talking about hospital-acquired pneumonia and ventilator associated. I'm talking about, yep, so hospital-acquired pneumonia and ventilator-associated pneumonia, you'd be giving pseudomonal coverage, and then whether you give two antibiotics for your pseudomonal coverage or one depends on your institution's antibiogram and the likelihood of susceptibility of the antibiotics uh, to Pseudomonas. Pseudomonas' susceptibility to the antibiotics you're going to give, right? So if someone has a hospital-acquired pneumonia, ventilator, or a ventilator-associated pneumonia, then you would be uh, wanting two antibiotics to cover Pseudomonas if your antibiogram doesn't have great uh, great coverage with just one. So I hope I hope that's helpful. It's kind of um, it's kind of something that takes a little bit of thought to kind of think about when it helps to double cover. So double coverage of Pseudomonas is based on guessing which antibiotic would cover it. You're basically placing bets saying, would one antibiotic cover it, or do you need a second antibiotic to cover it? But once you see, so if you take a culture and you get and it's Pseudomonas and you get the susceptibility report back, if it shows that one of them works or both of them work, you would pick one antibiotic and just use that one. So you're just essentially placing your bet on will my antibiotic work or not? So double coverage is two antibiotics until you figure out that one will work, and then you go with just one. Yep. So it's different than synergy. It's different than um, you know, continuing with two. Now, indications. So community-acquired pneumonia, levofloxacin or moxifloxacin would be considered respiratory fluoroquinolones, not Cipro. UTIs, pyelo, prostatitis, fluoroquinolones work very well, but if they're extremely sick or um, it's not working, then you'd need to change due to the high rates of resistance. Abdominal infections, combination with metronidazole for anaerobic coverage. Skin and soft tissue infections would be okay if your main thing that you're trying to cover is strep, right? So if you're giving levofloxacin to cover strep, infection, that would be an option. You wouldn't want to do that if you had a better option. If you could give a beta-lactam, that would be better. But if they have uh, if they have a penicillin allergy or they have a reason you can't give something that's more narrow spectrum, then levofloxacin would be okay to cover strep. Bone and joint infections would be okay to cover gram negatives. If you don't know, what it's from, I usually give something to cover gram negatives, and then also something that covers gram positives, including MRSA, if I'm not sure for like a toe osteomyelitis. Traveler's diarrhea. In the past, they used to say levofloxacin or azithromycin for traveler's diarrhea. If a person is going to a place like Asia, that's a large area, the amount of resistance to fluoroquinolones just in general is so high that now it's recommended to not give a fluoroquinolone. It's recommended to give azithromycin instead. And we have had patients that return from India and they're taking a levofloxacin or ciprofloxacin, it's not working, and then we give azithromycin, and then they get better. So it's just high rates of resistance. And I wanted to include this. We're not going to go through it too much, but just for something to have, I think this is pretty good. You can see ciprofloxacin is here. It has it as covering MSSA, but I wouldn't give it, especially for serious infections. Covers gram negatives. And then you can see that covers gram negatives well, but it doesn't cover anaerobes. Levofloxacin covers atypical causes of pneumonia, which we talked about a little bit with like Chlamydophila and Legionnaire's disease. And then moxifloxacin is down here and it covers gram negatives very well. It does not cover Pseudomonas. And then it covers anaerobes and some atypicals. I think this is good. Drug interactions, it can prolong the QT. So if you're giving multiple drugs, especially, that prolonged QT, it'd be very important to know that so you're not giving multiple drugs that causes a prolonged QT, cause them to go into torsades and causes them to code and their heart to stop working. If I'm going to give an antibiotic for a prolonged period of time, I will check an EKG, and if they have a QTC that's around 500 or so, I wouldn't give a fluoroquinolone. As far as absorption is generally good, but if you're giving something like uh, multivitamin or they're on calcium or magnesium or iron pills, I wouldn't give it at the same time of day. So I would give the fluoroquinolone, maybe in the morning, and then uh, their pills, their multivitamins at night, and just break it up so you can try to make sure that they get good absorption of it. And it can increase levels of warfarin, and so it's important to follow that closely. Now, I've tried to look for things like this before. This is one that I found as far as narrow to broad to extended spectrum. So if you're thinking about, whenever we try to give antibiotics um, for antimicrobial stewardship, you want to give the most narrow thing you can, so you're not interrupting their gut flora and you're not giving them things that might make them resistant, that might make the bacteria resistant to antibiotics you want to give in the future. So you want to give something narrow spectrum. You get things that are a little bit more broad, and really you can look back on that spectrum of activity sheet and see which ones are very broad and which ones are more narrow. Because ideally, we want to give a beta lactam and the most narrow beta lactam possible. So one of the things with when you get things that are really, really broad or covers anaerobes, it predisposes people to C. diff. And if um, and so fluoroquinolones also can be a high risk for getting C. diff in the future. Now, I think of sometimes in terms of questions. So here's a question. Here's a college student. He's a college athlete. He was had admitted for surgical repair of Achilles tendon. He's previously healthy. He was at basketball practice. All of a sudden, he felt sudden pain, and uh, after returning from Mexico and getting an antibiotic, what is the most likely antibiotic? So here, this is going to be acute. This is going to be tendon rupture. Acute. He had acutely had his Achilles tendon. Sometimes people will say they had heard a pop, and they're so what caused this? There is a association with fluoroquinolones and tendon issues, tendon rupture. Most of the time, it's in elderly adults that are greater than 65 years old. And it's usually close to the time they were on the fluoroquinolone. So, so this one, it can happen in any age, but especially if someone's older, that there would be at most risk. But these are the type of things that if a patient has issues with their tendons, you wouldn't want to be giving fluoroquinolones if there's a better option. So, fluoroquinolone associated tendonitis, tendon rupture, peripheral neuropathy, CNS effects, there are things that are things that you have to think about, especially if patients say, they ha already have an issue with their tendons. You want to avoid fluoroquinolones and myasthenia gravis. And essentially, you want to reserve fluoroquinolone use for only if you don't have a better option. If there's, you know, a beta-lactam or something you can give, that would be better. Now, as far as FDA warnings for fluoroquinolones, I wanted to include this because in we saw that, fluoroquinolones have been around for a long time and they're very good, but especially if a drug has been out and it's been used as much as fluoroquinolones, you're going to see a lot of the negative effects. So, 2008, they said increased risk of tendonitis and tendon rupture. 2011, the risk of worsening symptoms, those with myasthenia gravis. And these are FDA warnings that have been coming out. 2013, they had updates about irreversible peripheral neuropathy, so serious nerve damage. And then 2015 came out with more warnings about, uh, let's see, generally outweigh, yeah. So if you can, because of these negative effects, if there's anything better you can give, then try something else. So in 2016, they said, you know, because of all these issues, if there's anything that you can use instead of a fluoroquinolone, then try to give something else. Now, fluoroquinolones are very good drugs and they get in very well PO. So sometimes it comes down to should I give a PO fluoroquinolone or should I put in a PICC line for a different antibiotic? And then you have to weigh the pros and cons of PICC line versus giving a fluoroquinolone. And sometimes it's hard to measure risk and um, decide what would be the benefit versus harm benefit discussion with the patient. Now that was our kind of rapid review. Any questions at all about fluoroquinolones in general? I mentioned C. diff. C. diff. Um, Anytime someone gets something that covers gram negatives, um, especially if it covers anaerobes as also, then you're at risk for getting C. diff. So if a patient gets a fluoroquinolone and then presents with really bad diarrhea that's happening 7 to 10 times a day, then you know you would kind of implicate the fluoroquinolone and say, because of that, put you at high risk for C. diff infection. Um, so if there's a better option from a fluoroquinolone, then you're supposed to do that. But um, due to all of the risks and issues with fluoroquinolone use, but all but overall, fluoroquinolones are very good, and I use them very frequently. All right, thank you so much for joining. If you have any questions, um, actually, sorry, there's one more thing. I don't I don't know that I mentioned AAA. Um, I don't believe I mentioned AAA, but if a person has an aneurysm, they are at risk for aneurysm rupture or worsening aneurysm due to fluoroquinolones. And the risk, the overall risk is low, although although if a person has an abdominal aortic aneurysm, uh, you don't want to give a fluoroquinolone if you have any better option. So the risk of having it enlarge or rupture on a fluoroquinolone, it it's a low, but it's still it takes the low risk that they already had and it doubles it. So it doubles the risk of them having their AAA enlarging or rupturing. So it's kind of hard to think about, the how bad it just is if it's extremely low likelihood of enlarging or rupturing, but a fluoroquinolone doubles that risk. So if there are any better options, if you have an abdominal CT scan of someone and it shows that they already have a AAA, then you would avoid a fluoroquinolone if possible. Okay. All right. Thank you so much, everybody. If you have any questions, you can always uh, ask us any questions you have. You can always contact us anytime. Thank you so much.